It is my pleasure now to introduce our next wonderful speaker, Dr. Bincy Abraham. Dr. Bincy Abraham is an associate professor of clinical medicine, gastroenterology, and hepatology at Houston Methodist Weill Cornell, Houston, in Texas. She did her undergrad education in bioengineering at Texas A&M, and then did her medical school, internal medicine training, and gastroenterology at University of Texas in Galveston, with a master's in clinical investigation. She also was highly trained during her fellowship in IBD with rotation at Cedars-Sinai through the Crohn's and Colitis Foundation. She also chairs the Crohn's and Colitis Foundation Medical Advisory Committee in her local chapter. She has been the principal investigator and co-investigator on several key clinical trials and has a rich record of publications. And she will be debating pro de-escalation of therapy. Dr. Abraham.
Thank you for the kind introduction. I'm actually very happy to be here. And when I found out that I'm actually debating Scott Lee, I was like, oh my God, this is the no-brainer. This is easy. No one listens to 90% of what Scott says anyway, so it works out. So I really just have to have one slide saying de-escalating therapy is awesome in IBD, and that's all I need to do, right? Right. But I actually wanted to teach you guys something too. So I'll actually go through, what de-escalation actually means and a few points as well. So there are different types of de-escalation. So you could actually reduce the medication dose, perhaps the medication frequency, or perhaps even discontinue medications in someone with these chronic diseases that have this disease for the rest of their life and have to be on medications for the rest of their life. Right? So I'll go through the benefits of de-escalating therapy. So no matter what Scott says about the risk of it, there definitely are some benefits here. Outcomes after de-escalating therapy, so I have to just say it's good. We can actually see how patients did after de-escalating. And predictors of relapse of those patients you may not want to de-escalate therapy, and what do these patients do after you retreat in case they do relapse. Right. So general benefits of de-escalation, you all know that patients want to take less and less medications no matter what disease they have. There's a reduced pill burden, so they don't have to take as much medications, oral tablets or injections or infusions. And there's definitely a benefit of reducing costs. We're all about reducing healthcare costs, not just in the US, but all over the world. And so if we can de-escalate therapy in certain patients, will actually benefit overall healthcare as well. And of course, reducing side effects, which is a key component here. Right. Now, Scott will probably say all the stuff about de-escalating therapy is bad because he likes to do them, or he may do them incorrectly. And so you want to do it correctly. And this is the correct way to do it. Okay. So he's probably done this and learned from experience of incorrectly de-escalating, and gosh, all his patients end up flaring. That's because he did it in the wrong type of patients. He did it when they were probably in a clinical flare and increased the risk of their clinical flare. Not the time to do it, right? But if you do it incorrectly, there are some consequences. It increases the risk of their flares, prevents mucosal healing, and it can promote inflammatory activity, and of course, increase the risk of disease complications, hospitalization, surgery, etc. So that's really a no-brainer. You guys already know that. Now, with risk benefits, we always talk about that in IBD. There are actually risk of not de-escalating patients as well. And why would you want to continue a patient on medication when they really don't need it, right? And lymphoma risk is a major concern of all of our patients on immunosuppressive therapies. And this study actually showed that if you're on an immunomodulator or immunosuppressant, whatever you like to call it, they have a significantly increased risk of getting lymphoma in their lifetime. And the older that you are, much higher hazards of getting lymphoma. Now, if you stop immunomodulator or immunosuppressive therapy, the risk actually reduces drastically to the point of being not ever been on an immunomodulator. So keep that in mind, that there actually is true benefit reducing cancer lymphoma risk in these patients. Now, when do you not want to de-escalate? This is the things I'm actually having to teach Scott to do. Or not to do in practice. So you don't want to do it when a patient's in a clinical flare. Okay. Patients with subtherapeutic drug levels, not the time to do it. Patients that have mucosal inflammation, and ideally, you would like to have these patients without histological inflammation or histological normalcy. Now, we may not ever achieve it, but this would be an ideal situation. You don't want to do it just because a patient asked you to. I know Scott always tries to be nice to his patient. He thinks, can I stop all my medications? And he said, sure, why not? We'll stop it. It's all good. We should, de-escalate, and this is when patients flare. And of course, during pregnancy, because you're not only taking care of the patient, but also the baby as well. So when would you want to de-escalate? Well, the opposite of all these factors, right? So ideal situation when you have patient in clinical remission, healing, ideally in histological healing as well, short disease extent, and adequate drug trough levels. Okay. So you could de-escalate by reducing dosing, as I had mentioned earlier. If they're on combination therapy, you could discontinue the immunomodulator, or you could consider discontinuing the biologic, and I'll go through studies looking at the data regarding that. You could consider stopping both medications, but this really is not a debate on discontinuing all medications, so I would not recommend that. That would be a very small, minute number of patients that you would consider doing this. Okay. Right. So let's look at discontinuing immunomodulated therapy. There actually was an open-label, randomized controlled trial that looked at Crohn's patients in remission for 6 months or longer on combination infliximab and immunosuppressant therapy. They were randomized to either continue or discontinue immunomodulated therapy. 40 continued and 40 discontinued. They followed up to 2 years. And we found was, regardless of continuing or discontinuing immunomodulated therapy, there was actually no need for these patients that were in remission to have early rescue infliximab therapy or adjusting their dosing, or even discontinuing their infliximab due to adverse events or immunogenicity, for that matter. So these patients actually did quite well, regardless if you continue or discontinued. So if they didn't really need to continue their immunomodulator, my thought is, why continue them? Just go ahead and discontinue. They will actually do quite well. Now, you can actually use some guidelines. You don't have to do this blindly. And I mentioned, checking, looking at therapeutic or trough levels, and you can use the trough level as a guide. So this study actually showed that if you have a patient with infliximab trough levels before their next infusion of 5 microgram per milliliter or larger, you can actually see that patients continue to remain responsive to infliximab while you discontinue the azathioprine. Now, if you have low levels but detectable, less than 5 micrograms, then you have a few more of your patients actually not responding and potentially going into a flare. Now, what you don't want to do is stop immunosuppressant therapy if someone has undetectable levels, because either the azathioprine, 6-MP, or methotrexate is driving the disease management here, or preventing antibodies or possible consequences from their infliximab therapy. Now, there's another trial. You don't look at one study, right? There's another study proving my point that this was actually a prospective, multi-centered cohort study looking at patients all in clinical remission on infliximab and some immunosuppressive therapy at 1 year, and over 6 months of steroid-free remission. They had 115 Crohn's disease patients, and they all discontinued infliximab and followed every 2 months for more than 1 year. And they looked at time to relapse after infliximab withdrawal, and also looked at factors associated with relapse risk. What they found was 44% of your patients did relapse after 1 year. But if you look further, 2 years is about 52% of patients. So you did capture some of these patients who did relapse, but those actually remained stable over 2 years. Now, Scott might use the same study and say, and be pessimistic and go, well, look at all these patients who actually relapsed, right? But I actually think of the glass as half full. How about these patients who remained in remission and did not relapse? Let's look at those and see what those risk factors were for those that did relapse. Okay. So they looked at clinical as well as some biological or biomarkers of risk factors for relapse. And what they found that if you had multiple factors. You don't necessarily have to have that exact ideal patient to discontinue therapy, but if you have someone who has low hemoglobin, high white count, high inflammatory markers with CRP or calprotectin, not in mucosal healing or low trough levels, then you have a higher risk of relapsing. Or if they're male gender, steroid use within a year before you stop infliximab or no prior surgery. These are some of these factors. So less than 4 of these factors, you actually have a good chance of remaining in remission without a relapse. But if you go to 5, 6 or more of these factors, you have a high chance. So in this case, you can actually look at your own clinical setting, your patients, and go, do these patients have any of these risk factors? If they don't have any at all, you can actually pretty much assume they're going to do quite well if you discontinue in their therapies. And let's say you did discontinue therapy, could you monitor them to capture them before they end up in a clinical flare? You can actually if you follow their CRP or their calprotectins. In this study, high CRP as 6 or higher, calprotectin is a cutoff of 300 or higher. Actually, we're able to find out which of these patients will end up having a clinical flare 2 to 4 months before they actually went into a flare. So after you de-escalate therapy, you can actually follow them with their laboratory markers. You don't necessarily have to rescope them every time. If their calprotectin starts going up or their CRP starts actually going up, you can do something about it sooner than later. Now, how about those patients who did relapse? Well, you actually can retreat them, and they do quite well. So 62 relapses occurred during this study. 52 patients were treated, and almost all of them, 98%, had a clinical response or retreatment with infliximab, the same medication they were on that they were discontinued previously. 88% actually went into clinical remission. No adverse reactions occurred, and retreatment was well tolerated. So even if you do have a patient who relapsed, you can actually retreat them, and almost all of them will actually feel better. Now, let's look at another study looking at discontinuing anti-TNFs. And this is really hot off the press because I told, I have one enemy in Seattle, but I have many friends elsewhere in the world. And so I gathered all my Spanish colleagues and said, hey, I need to do something. I have this debate against Scott Lee coming up. I know we talked about, de-escalating therapy in the past. Can you just get me all the data and publish it right away? And sure enough, they came together and did this and published it like practically last month, ready for me to prepare for the slide lecture for you. So this was a retrospective study. So we're I know it's not a prospective one, but actually looked at over 1,000 patients with both ulcerative colitis and Crohn's on either infliximab or adalimumab, and other medical therapies as well. They looked at who discontinued therapies, and discontinuation could have been related to different reasons: elective decision either by the patient or the physician, onset of adverse events due to the medication, or due to combined therapy as a step-down version, in that sense that they started with combined anti-TNF and thiopurine early on, they got better, and they were able to discontinue that medication. And how did these patients do? The relapse rates were actually pretty low, 17, 19%, both UC and Crohn's disease. But if you looked at those patients who were continued on or treated with immunomodulated therapy, actually the relapse rates were even lower. So keep that in mind. If they're on some other medication, you could consider discontinuing their anti-TNF, and those patients tend to do a little bit better than those who were just taken off completely. They also looked at factors associated with relapse. And again, what you see is that elective discontinuation, meaning the patient decided to stop it or the physician just said, oh, let's just stop this medication, not good. They had adverse events, and that was a recent discontinuation, not so good. However, older age and maintaining immunomodulators were actually protective, so keep that in mind as well. And in Crohn's disease specifically, colonic disease and strict chewing behavior were actually risk factors associated with relapse. And they also retreated their patients pretty quickly, and you found that they responded at 14 weeks, 67% were back in remission, and a quarter actually had partial response, but only 8% had no response. So a really small minority of patients who didn't really respond to the same retreatment. And at the end of follow-up, 75% remained in clinical remission as well. And if you compare UC versus Crohn's disease, again, similar numbers here. 3/4 of your patients went back into clinical remission, and only about 10 to 15% had no response to retreatment. So you're able to get these patients back, majority of these patients back with the same anti-TNF. Right. Now, I also mentioned dose de-escalation as well. There was another study, again proving my point, that you can de-escalate by dose reduction. And these were patients, 67 patients who had high trough levels of infliximab, over 7 microgram per milliliter. And when they reduced their dosing, they actually maintained their disease control, looking at HBI, Harvey-Bradshaw index scores, or their partial Mayo scores for ulcerative colitis. And the CRP levels, you might say, well, those are activity index scores. You really need more objective evidence. The CRP levels also stayed the same once you dose de-escalated their infliximab therapy. So they didn't need as much drug, either their infusion or frequency-wise, and they did quite well. So I just wanted to run a simple case. I have several cases of successful de-escalation in my practice. I just want to say, well, we have all these large base studies, but this is a simple case that I want to say, well, this is one of my own patients that I did. This 27-year-old male, small bowel stricturing Crohn's disease. He had jejunal, ileal, multiple strictures and required stricturoplasties in the past. And he was on adalimumab 40 milligrams every 14 days, standard dosing. But he actually required dose escalation during this time period to 80 milligrams every 14 days because he had low trough levels and recurrent bouts of these small bowel obstructions. He underwent surgery, successfully, and did well on this dosing in clinical remission for 4 years. And during this time, he did not have any adverse events. But after 4 years, he came to me saying, "Well, I've been going back and forth to the ER, to my primary care doctor, and getting all these skin infections, abscesses, and requiring IND." It's like, this is not good. Where is this popping up from? And I checked his levels because he's been on a higher dose for quite a while, and I know. We talked about Loeb's law, and my thought was, if it's not broken, let's not fix it. So I maintained him on this dose for quite a while. But since these infections popped up, I checked his levels, and his trough levels were actually pretty high, 20, which is, more than therapeutic dosing right here. So what I did actually was I dose reduced to 40 every 14 days. And since then, all of his abscess cleared. He had no further infections, and he still remained in clinical remission. So in conclusion, I would like to say that dose de-escalation therapy can be done safely and successfully in the correct patient population based on clinical biomarker endoscopic remission, and of course those that have therapeutic trough levels of drug. And you can actually avoid preclinical relapse by monitoring these patients after you dose de-escalate by closely checking their CRP, calprotectin levels, and their drug levels as well.